Thank you, Sameh. Thank you, everybody. Wonderful to meet you. I assume you're seeing my slide and hearing me well. So this has been a fantastic day focused on the brainstem, and I'm delighted. And I am sure you will hear me probably repeat some things other speakers have said, which is good. It means we agree on certain things. So I'm going to jump straight into it. Disclosures are irrelevant. I will try to cover, you've had some beautiful anatomical presentations earlier, so I will skip through some of my anatomical things, surgical principles, and case examples. Anatomy, you know what it is. You've already seen those things earlier. I like to think also in cross-sectional anatomy between the medulla, the pons, and the midbrain, rostral, caudal, and so forth. And very quickly, I know you've heard it all before, but I mean, look how dense the brainstem is with important structures. This is the rostral midbrain. Look at all the important things that in normal anatomical specimens you cannot touch, because in a patient you cannot touch, you will injure many things. Look at the caudal midbrain. The pons is more forgiving. It has more so-called non-eloquent zones. It's a larger volume, so that's why you get away so easily by going through the middle cerebellar peduncle. And the medulla is very dense again. And as you can see from Giuseppe's last case, he had to give it a lot of thought to decide how to get in through the floor of the fourth ventricle and so forth. And that's a caudal medulla. That was pure anatomy. How about surgical anatomy? Again, we have to go back to Albino Bricolo, who, of course, the younger generation probably doesn't know. Of course, he passed away several years ago now. But Albino was the first one to start introducing the concept of safe entry zones and no-fly zones. And these diagrams are really based on his original work. The risky areas on the left, the relatively safe entry zones on the right. This is from Spetzler's papers. I've put for you the green incisions in green, which are understood by most of us to be safe entry zones. You can see them anteriorly or posteriorly or laterally. However, these ones I put in yellow that I think are terrible approaches, even though some people may consider them acceptable. For example, I would never go through the middle of the pons anteriorly, unless again, we're talking pure anatomy. I don't want you to factor in a cavernoma there. I'm talking pure anatomy. Look at the middle picture. That's between the medial longitudinal fasciculi. And the two green dots, one is suprafacial, one is infrafacial. And my favorite ones are the bottom right picture, the supratrigeminal zone, the peritrigeminal zone, and the lower pontine zones. They're all around the trigeminal nerve. Another area, which of course is not nice at all, would be to go between the medullary pyramids. That's why it's in yellow. But going through the olive or a peri-olivary, that is good. Going through a dorsal myelotomy, as you can see in the bottom right picture, that is also often necessary. So when you summarize all the most common approaches with these green arrows, this slide summarizes kind of most of the incisions that you can think of to enter the brainstem: midbrain, pons, and medulla. Of course, as you've already seen, numerous surgical approaches. I am not going to list them for you, but you can see them and here. So what are the first lessons I learned from just the anatomy of the brainstem? To avoid complications, you've got to understand that anatomical structures get displaced by the lesion. And Giuseppe Lenzino made this point in his talk. very important, the mostly displaced rather than destroyed. And obviously, that's what you have to keep preserving in your surgery. So, what are the surgical principles? The coming few slides, I believe, are the most important part of my talk, probably more important than the case examples I'm going to show you. So, hang on with me here to go through them. You have to have goals, you have to have strategies, and you have to have tactics. The goals is the concept of conceptual reasoning. The strategy is the analytical planning of the surgery, and the tactics is what are the tricks that you use to go through these strategies to achieve the goals. So now I want to put these goals, strategies, and tactics in one big slide.
Excuse me, Dr. Marcos, you fell off your screen share, you fell off your presentation.
I did? Oh,
Yes, yeah.
okay.
Okay.
All right, excuse me.
Okay.
Let's try again.
Okay.
The mysteries of the computer, huh? I have no
Yes.
idea why that happens.
Yeah.
Do you see it, John?
Yes, I do.
Okay, thank you. Uh, there are 4 steps to each one of these. The goals, how to get there, how do you find it? You remove it without leaving any trace, and you resect it completely. For each one of those goals, it has strategies, surface geometry to know how to get there, depth geometry to find it, optimal intraaxial neural pathway, so you leave no trace. And very important, some of the audience was asking the question earlier, the microsurgical ergonomics, that's key in resecting the lesion completely. In the last column, I'm not going to read it all, but there are tactics that subserve each one of those strategies. And I'll get back to those maybe as I'm showing you examples. But that's how every time I have a brainstem cavernoma to operate on, I think of this slide in my mind, and I go through these steps in my mind. So, what mistakes have I made or have I seen others make, and what are the most common mistakes, and what do we learn from them? So there are many mistakes I could list, but I chose, I think, the most important ones. Number one, not knowing when not to operate, meaning when you are inappropriately aggressive. Number two, when you are inappropriately conservative. I am glad, for example, Dr. Lenzino chose to operate on this medullary case because the patient was getting worse. So that's good. Number three, very important, anatomy does not equal pathology. The safe entry zones, what you heard me just give you, what previous speakers have talked about, are almost meaningless when there is a lesion, a cavernoma that distorts the anatomy. Then, of course, you have to think differently. Favorable geometry does not mean favorable physiology. For example, this old paper of Adam Brown and Bob Spetzler, the two-point method. Of course, it's incomplete. That's not the only way you choose an approach. Many times, you should not use the two-point method. What I mean is the so-called obvious entry point is not always the safest entry point. And this is very true with the entry into the fourth ventricle. And I'm going to come back to that again through the example. I too, to answer Atul Goel question to Giuseppe, whenever I can, I avoid entry through the floor of the fourth ventricle unless the lesion is exophytic, not just on the surface, but exophytic in the fourth ventricle. Now, if you remember my slide, if you do poorly with step number 1 or step number 2, you will do poorly in step number 3 and number 4. If step number 2 gives you a certain approach and step number 3 gives you another approach, always favor step number 3 because it's more important. Next, if you think of cavernomas as round mulberry, like everybody describes them, you're gonna have mistakes. You have to think of it as a red cauliflower. Why? Because you can see the picture of a cauliflower. It has protruding irregular parts, and if you cut through one of these parts, you will have a residual lesion and will have a problem, and it could recur. I always sacrifice the small vein, not the main DVA, but the small vein that drains the cavernoma into a main DVA. I was too conservative early on in my career, and I would save every piece of vein, and I've had some recurrences in 2 or 3 cases, and I gone back. So I believe the small veins need to be removed, not the big DVA, but small veins draining those the cavernomas. Radiosurgery has no role in brainstem cavernoma. Surgical approaches, you can think of this problem in 2 different ways. Either you think of all the targets you can reach and the approaches that you can get to, or the other way around. You can think of all the surgical approaches you're familiar with, and each one of them, what target can it get you to? So Spatzler, I believe, still has the largest series in the literature, and in his series, still, look at the numbers. In the hands of a master, new deficits in 53% of the cases, resolution of pre-op symptoms only in 1/2 of the patients, and new permanent post-op deficits in 35% of the patients. So this is, there is definitely room for doing better. Kalani did a meta-analysis of the literature, pretty much same results. So Roten, I'm going to use some of his diagrams to show you the various approaches. Terminal, COZ. By the way, it's best for the anterior midbrain, the transsylvian pretemporal plus or minus transtentorial is best for the lateral aspect of the cerebral peduncle. The Kawase approach is best for this ponto-mesencephalic lateral surface, midbrain and upper pons, not lower than 7th and 8th nerve. I love this approach. Supracerebellar infratentorial paramedian is usually my favorite as opposed to the midline. That's best for the dorsal midbrain, as you can see. Posterior interhemispheric transtentorial. I don't like to use self-retaining retractors, so I put the patient in the lateral position for the head, and I don't use a retractor. I just use lumbar drain and let the parietal occipital lobe fall away from the falx. I may put a retractor on the falx, but not on the dependent brain. And that is a very useful approach. Midline suboccipital, of course, for the floor of the 4th ventricle. Retrosigmoid is a very powerful, versatile approach for the entire side of the pons and upper medulla. Rarely used is the pre-sigmoid subtemporal posterior petrosal approach. If you have a really particularly difficult angle, the far lateral is extremely useful for the upper medulla and lower pons. So what lessons have I learned from these various surgical approaches? Well, planning a surgical approach to an anatomical structure is not the same as planning it to approach a pathologic process. Always choose the simplest approach that provides surface access to the tumor and the correct access of resection. So I think I have about 10 more minutes, so I'm gonna zip through a few case examples from the top down to the medulla. I'll skip through several because of time. Let's start with the midbrain, where I used a posterior interhemispheric supracollicular transpineal gland approach to get to this thalamo-mesencephalic cavernoma. I'm going to skip the history. A patient had failed Cyberknife, and you can see in this video where the lesion is. Somebody else had given Cyberknife radiosurgery. So here is the lesion. You can see it. It's almost pan midbrain. It erupts into the third ventricle. You can see it here again. And here again on sagittal. You certainly don't want to go through the collicular plate because you'll create eye movement problems. So I thought the best entry is where the red dot is, where the pineal gland is. So posterior interhemispheric approach. You can see I took one bridging vein, no retraction. We are going to cut the tentorium. We have a lumbar drain. Always beware where the straight sinus is. So here is a straight sinus. I just marked it. I like to open the tentorium, not from its edge, but from the middle towards the edge. We are going to cut all that. And of course, you will have an excellent view of vein of Galen. Here is vein of Galen and Rosenthal and the precentral cerebellar vein. And this is a quadrigeminal cistern. And we're going to cut the arachnoid extensively. And by using navigation, I can immediately see where I need to go. I am going to go, you will see it in a second. This is a pineal gland. All good? All good? Yeah, I mean, thank you. This is a pineal gland, and I'm going through it behind, above the collicular plate. In an adult, we don't really need our pineal gland, and you will see, look at the view. I'm in the hemorrhagic cavity above the superior colliculi, and the cavernoma resection is very easy. Once you're inside, you develop a gliotic plane. You stay within the gliotic plane and coagulate whatever is necessary. And try to remove it in one piece when possible. That is always my strategy with cavernomas. So I think this angle of approach was perfect. You can see the brain is very nicely preserved. Look at the room I have from lumbar drainage. And here is a post-op MRI. So the lessons from this case is choosing the angle, visualizing the vein of Rosenthal and the pineal gland entry. Those use gravity rather than static retraction. Straight sinus is not always easy to identify. And another example how radiosurgery has failed in a case of brainstem cavernoma. Let's go to this one. This one I used a supracerebellar, infratentorial, extreme lateral. I don't like the sitting position. I do all my cases in the Concord position for a midbrain superior cerebellar peduncle cavernoma. Another surgeon 6 months before had done a failed telovelar approach. I'll show you the case. She's 28-year-old, presented with hemorrhage, a fourth nerve palsy. This is her original presentation to the other surgeon. You can see the hemorrhage. Now you can see he looked at, I guess, at the sagittal and thought, well, maybe the best way is through telovelar from below up, but that's a long way. And of course, not only that, but there was a large DVA, developmental venous anomaly, covering the posterior surface of the cavernoma. And here it is beautifully seen on an angiogram. Uh, so he got in, only removed a small piece and backed out. That's a post-op scan from that surgery 6 months before she was referred to me. She recovered actually quite well. The fourth nerve palsy disappeared. But now she comes to me, of course, with her cavernoma still there. Now, what is the best approach here? Well, to me, it's very obvious and very clear that the best approach is supracerebellar infratentorial. That's where the lesion reaches the surface. Why would you go to the fourth ventricle to get to this? You shouldn't. So again, to show you briefly what the view looks like, here is the MRI. Oh, by the way, look at the hematocrit level in the hemorrhage in the lesion, these hemorrhagic ones, and concord position. And within a few minutes, I am looking at the cavernoma. It's presenting itself on the surface. Sharp dissection, identify, this is concord position. I'm using dynamic retraction with my sucker. I will not I did not need to use a self-retaining retractor. Look at the beautiful view, the multiple colors. Look at the fourth nerve. I will be working mostly below the fourth nerve. You can see the fourth nerve here. And here is one of the branches of the superior cerebellar artery. I am mobilizing it, getting it out of the way. But if necessary, you can work below and above the SCA. That's what I will be doing. Coagulating, shrinking the lesion. The rest is, same for everything. I like to use these non-stick, disposable, irrigating bipolars. And I'm not going to show you the complete resection. And here is the lesion. And look how nice and clean the wall of the cavity is. But it's never enough. You really have to inspect every corner. It's very easy, as I said earlier, to miss residual cavernoma. So when you're not sure, cut into it, coagulate it, keep challenging the piece of the wall you're suspicious of till you're absolutely certain nothing is left. And you can see the superior cerebellar artery hanging in midair. And again, at the end, that cerebellum is not bruised. It looks good. Again, using good CSF egress and a concord position, not purely prone, but concord. And here is the post-op no residual. Patient did have a fourth nerve palsy after my surgery, but it recovered completely. That's a post-op. Lessons you heard me say. I'm going to go quickly on a couple more cases. This woman was 36-year-old and she was 23-week pregnant. She actually lived, she's in Panama, Panama City. She bled 3 times. I'm skipping some of the history. They gave her steroids. She became wheelchair bound, not only because of the cavernoma, but because of the steroid myopathy. And look at the acne on her face and her lung, on her chest, because of weeks and weeks of Decadron, and because they felt that this lesion cannot be is inoperable. Well, of course it is operable, but how? One way you could choose would be telovelar through the floor of the fourth ventricle. But my lesson or my warning to you is don't do that, even though it looks like it would be easy, because the facial nucleus will be there and the patient had no facial nerve palsy. What is the easier, the safer approach? Of course, simple subtemporal. That's what I did. Keep it simple, and that's what I did. I'm not going to show you the video. Here we are monitoring the fetus when I operated on her. The baby did very well, and I removed it. Simple subtemporal approach, no skull base modification, no nothing. And she did so well. her hemiparesis was already improving post-op day 1. Her third nerve palsy did not change, at least immediately post-op. And I don't have a picture of her. I saw her, of course, after the baby, she delivered the baby, and 2 years later, completely recovered, remarkable recovery in this, where she looked so bad. I think I have time maybe for one more case quickly. I'm going to show you this one. I want you to think of the horizontal fissure of the cerebellum as the equivalent of the sylvian fissure of the supratentorial compartment. Here is what I mean. This is presenting the case of. This is a 26-year-old woman who hemorrhaged. Here is her cavernoma. Cavernoma with the hematoma in the right side. It's spanning the entire pons. Here I'll show you on a rostrocaudal. So it's an entire pons. So you could think of many approaches, including simple retrosigmoid. I didn't want to use the Kawase approach. It was too low. I wouldn't be able to reach the lower part. The far lateral approach wouldn't easily reach the upper part. So I said, well, I'm going to do retrosigmoid, but I need to look more medially. So how do you do that? Let me take you straight to the video. Retrosigmoid here. So here you're doing a simple retrosigmoid. Well, so I'm going to let the narration say it. On the left side and the suprameatal bone in between the two. Right here. Move to expand. So I'm going to freeze it a second. This fissure is so-called petrosal fissure, or the horizontal fissure. It separates superior semilunar lobule from the inferior semilunar lobule. Split it, and that's what I'm going to do. Remember the view you have right now of the brainstem, and compare it to the view I'm going to get after splitting the fissure. So I'm going to speed through it. It's like very sharp. Here are the superior and inferior semilunar lobule. I'm reminding you from Rothen's anatomy where we are. This is also called the petrosal fissure. And you're separating the petrosal surface superiorly from the petrosal surface inferiorly. Look now at the view. You see, after I finish splitting, I am going to enter through the middle cerebellar peduncle. Here, right here, the peritrigeminal zone. And then it's a perfect approach, and the lesion is out almost